first scientific session, which is on maternal medicine. And our first presentation is from Dr. Asma Bano. She is a ST4 specialty trainee from University Hospital of Wales, Cardiff, and she had not been able to join us for this. However, we'd have it via Zoom. So it is about documentation of obstetric review, counseling, and clinical decision making prior to initiation of syntocinon for augmentation of labor. We felt that it's an important session to talk about as well, because it reflects and presents an audit on the process, and it would be very helpful for our own students as well. So before we start this session, for maternal medicine panel, I would like to invite Dr. Aisha Malik on stage, Dr. Rehana Malik, Professor Dr. Shahida Sheikh, Dr. Shahina Asif, Professor Dr. Shamsa Hamayu, Dr. Zaryab Setna, and Professor Dr. Tabinder Rana, please. Expert panel for the poster review include Dr. Aftab Munir, Dr. Asma Gul, Dr. Aisha Siddiqa, Dr. Fariha Khan, Dr. Halima Yasmin, Lamia Yusuf, Luman Sheikh, Dr. Nadia Khurshid, Dr. Nahid Jamal Faruqi, and posters would be reviewed between 12 midday to 1 p.m. So let's rewind and we restart. So our first presentation is an audit basically from which is being presented from Cardiff and Wales University Health Board, UK. And it's about documentation of obstetric review, counseling, and decision making prior to initiation of oxytocin for augmentation of labor.
Good morning, my name is Dr. Asma Bano Ali. I'm an obstetric and gynecology ST4 trainee at the University Hospital of Wales in Cardiff, United Kingdom. Today I'll be presenting our audit, documentation of obstetric review, counselling and clinical decision making prior to the initiation of syntocinon for augmentation of labour. This work was carried out at Cardiff and Vale Health Board under the supervision of Mr. Mark Osmond, who's the consultant, and with the help of Dr. Dina Yusuf. Syntocinon, a synthetic oxytocin, is widely used to augment labour, with 20 to 30% of UK labours requiring augmentation, making this one of the most commonly used obstetric interventions. However, it does carry both maternal and fetal risk, and therefore national guidance, including NICE interpartum care guidelines, clearly outline the requirements that need to be fulfilled before starting a syntocinon infusion. These include performing a full obstetric assessment, excluding obstructed labour, confirming labour delay, and documented counselling. In terms of counselling, both risk, benefits and effects need to be counselled on and recorded, and these would include risk of fetal hypoxia, uterine hyperstimulation, the need for continuous fetal monitoring, and stronger contractions, to name a few. In 2024, the University Hospital of Wales performed a clinical risk review, and it identified variability in documentation with syntocinon augmentation, leading to concerns around patient safety and medical legal protection, and this audit is a direct result of that clinical risk review. The objective of this audit, therefore, is to assess whether documentation for syntocinon augmentation meets NICE standards, and focusing on obstetric review, counselling and consent, and ongoing management documentation. The audit was a retrospective audit set at the University Hospital of Wales between June 2024 and June 2025, and 34 maternity notes were reviewed. Women who presented in spontaneous labour were included in the study, and women who required syntocinon for induction of labour were excluded. The performer was set out in 5 different sections, which including assessing for syntocinon, counselling and consent, documenting and prescribing, monitoring and assessing progress, and assessing signs of obstructed labour. In terms of results for assessing for syntocinon, by far the most common indication for initiating a syntocinon infusion was failure to progress, and this was defined as less than 2 centimeters cervical dilatation in 4 hours. Other indications include decreased contractions and lack of descent of fetal head. We assessed whether there was an in-person obstetric review done prior to the initiation of syntocinon, and we found this was in 68% of cases, while in just over a third this was not clearly documented. However, there is a point to note that in many of these cases, the in-person obstetric review occurred much earlier in the labour rather than just prior to the initiation of syntocinon. We also assessed whether it was the same clinician who performed the last 2 vaginal examinations that led up to the decision of syntocinon, and we found that in the vast majority, 65% to be exact, it was a different clinicians that performed the last 2 vaginal examinations. And this really reflects the shift change pattern and the multidisciplinary nature of labour ward. In terms of counselling and consent, the results were much more variable. Discussion of starting syntocinon infusion was documented in 38% of cases, while specific risks such as uterine hyperstimulation and fetal hypoxia only recorded in 12% of cases. The benefits of syntocinon infusion, including reduced time to delivery in 18% and explicit verbal consent, only found in 35% of the maternity records. So what these findings really show us is that whilst discussions may be happening at the bedside and happening with patients and partners, they're not being documented consistently enough. And consequently, this has implications for patient safety and medical legal protection. In contrast, documenting and prescribing treatment was done well. The start time was found in all cases. The infusion was prescribed and signed by an obstetrician in 94%, and the appropriate regime documented in 91% of cases. So what this really shows, this overall slide, is that whilst the practical aspects of prescribing and initiating treatment are done consistently well, the counselling, the consent and the discussions are poorly documented. Moving on to monitoring treatment and progress, the proposed next vaginal examination was documented in 59% of cases, meaning that over half our patients had a clear plan for reassessment. The time taken for target contractions to be achieved and the dose at which they were achieved were recorded at 82% and 88% respectively, while sodium levels were documented in only 38% of cases. What this shows is that while some elements of monitoring are done well, other key parameters recommended by national guidance are much less consistently performed. In terms of obstructed labour assessment, 77% of patients had an obstructed labour assessment documented. However, these assessments were not comprehensive and focused only on 1 or 2 clinical signs. Additionally, what we found was that the majority of these assessments had been performed after the syntocinon had already started. In terms of outcomes, 32% of women had a normal vaginal delivery, 41% required an instrumental delivery, and 27% underwent a caesarean section following syntocinon augmentation. So in conclusion, documentation of syntocinon augmentation is inconsistent and frequently below national standards. Risks, benefits, target contraction range and counselling are particularly poorly documented. Clinical reviews do occur but are not reliably recorded at the point of decision making, and poor documentation impacts patient safety, informed consent and medical legal protection. Therefore, future work will focus on developing a standardised Badgernet performer, almost like a checklist, to improve compliance, and we aim to re-audit in 12 months. Badgernet is the computer system that we use at the University Hospital of Wales for maternity. Thank you for listening. I'd just like to thank the maternity teams at the University Hospital of Wales for their support. Also very grateful to Mr. Mark Osmond for his guidance and oversight, and to Miss Mina Ali for her encouragement and continued support. A very special thank you also to the conference organisers for the opportunity to present this audit. I've listed my references below. Finally, just wanted to say thank you once again for the opportunity, and I'm just so sorry that I'm sorry and disappointed that I'm not there to present this in person. Thank you.
Thank you so much. So basis of an honest is actually initial honest documentation of when things are not right. Only then we can improve them. Our next presentation is also a virtual presentation, and that is from Dr. Wasim Lodi.
Assalamu alaikum, everyone. I'm Wasim Lodi. I'm going to talk on effective clinical escalation today. Effective clinical escalation is essentially raising our concerns when we identify a clinically unsafe sort of situation. Now, a lot of time we don't do that because of the fear of our seniors. Sometimes we don't even notice that something is going wrong, and hence we miss the opportunity to escalate it to our seniors. It's a very useful, effective tool which improves patient safety, and I hope you will find this talk useful. So my aim is that by the end of this session, you should be able to understand why escalation matters in obs and gynae, and what are the risks of that, and what are the tools available, and then how we can apply it in our practical life. Escalation basically is the recognition of a deteriorating condition that you communicate to a senior colleague. It could be a medical colleague, a nursing or midwifery colleague, and then you devise a management plan for that. There are some factors which contribute to that. The most common one is communication. A lot of time we are not very clear in our communication. In one of my previous talks, in one of the previous summits, I talked about mitigated speech, that जैसे पाकिस्तान में हम लोग clearly बात नहीं करते, हम गोलमोल सी बात करते हैं. That is one. Another one is that हमारे मशरकी culture में एक चीज़ जो which is very common, वो ये है कि जब हम कोई बात करते हैं तो ओनस दूसरे पे होता है कि उसने समझना है. मैंने कह दिया, अब तुमने आगे से समझना है. However, it should be the other way around. Because West में ये होता है कि अगर आप किसी को कोई बात कह रहे हैं तो then you try to make sure that the other person understands. So communication is very very important. And also दूसरा ये होता है कि हम बहुत दफ़ा मिन बहुत करते हैं, clear बात नहीं करते. और उसकी कई दफ़ा वजह ये भी होती है कि हमारा कल्चर इस किस्म का होता है, जो एक डिपार्टमेंट का, कि वी आर स्केयर्ड ऑफ आवर सीनियर्स, वी डोंट वांट टू रेज आवर वॉइस, कि दूसरे को पसंद नहीं आएगा, या आपका वो बॉस जो है वो इतना खौफनाक होता है कि दे डोंट लाइक कि कोई उन्हें क्वेश्चन करे या उनसे कोई बात पूछे. एंड ऑल्सो कि हम कई दफ़ा एक खुद ही डिसीजन नहीं कर सकते. We are so indecisive that we just think, okay, इसके ऊपर अभी थोड़ी देर और बैठ के इंतजार करते हैं. So you have to think of that. So communication, clinical culture, and decision making. These are the main barriers. And if you get them right, then you can facilitate patient safety in your department. As I mentioned earlier, that obs and gynae is a high risk specialty. And here we have a mother and a baby. And if we delay escalating any concerns, it can have significant impact on mother or the baby. So that is why it is important that we identify any concerns early and then communicate it to our colleagues from whom we need any help, and then we act on it in a timely manner. You may have heard that obstetrics or the maternity service in UK are under a lot of scrutiny. Different reports have come up, like a Genden report. And these are all those reports which have been looking at adverse events in maternity. RCOG has a program as well, which is called Each Baby Counts. And in this, basically, they look at reasons why adverse events happened during the maternity care of a patient. And one of the major factors which has been identified is failure to escalate. And this is why I feel that the today's session is important, that a lot of time things go wrong because we don't raise our concerns. Remember that escalation is not just calling for help. In escalation, the first step is that you need to identify something is going wrong. You may have seen that we plot vital signs on Muse charts, and then if we see that the pulse is rising, respiratory rate is rising, or the blood pressure is dropping or increasing as depending on the clinical situation, then we need to do something about it. And then we are going to communicate it to our senior colleagues. Then we need to either get advice from them, we may be just informing them so they are aware of the situation, or we may want them to do something about it, and at an appropriate time as well. Our COG's Each Baby Count Escalation Toolkit has three core interventions. One of them is teach or treat, that if you feel that there is no need for a concern, and especially if your colleague has escalated to you, then you teach them that why you think there is no need for any concern. And then if they have asked you for help in managing something where immediate intervention is required, then you can deal with the situation and then later go with your colleague to go over the situation. The other one is that whenever you are escalating, you should be clear in your mind whether you are doing it just for advice or informing the other colleague, or you want them to do something. So remember the mnemonic 8. And also then we'll talk about teamwork, because teamwork is extremely important and we as seniors have a duty to promote that in our departments. I will talk about these more in detail later. This is a video that we made in our department. I want you to have a look at it. There are two components of that. In the beginning, you will see that a midwife comes to registrar to escalate a concern, and registrar is busy on her phone, and see how the registrar is dealing with the concerns of the midwife. Then in the second part of the video, you will also see that the midwife is escalating her concerns, and then when she says that she's going to escalate it to a consultant, then how the registrar explains to the midwife why she's not concerned, what is her plan, and how she's going to deal with that situation.
Hi, Miss Suba. Sorry, can I talk to you for a minute, please?
Yeah.
Yeah, I have this CTG for my lady. I'm not really happy about the baseline is going high, the variability is not really there. So can you just come and review my lady, please?
Sorry, who's this?
Yes. This is patient in blue by 3. She's here for an induction. She's 33-year-old, paranoid. We're meant to start the induction, but I'm not happy with the CTG. Can we just review her?
What's wrong with the CTG?
So, as I said, the baseline is going higher. It was 140 before, it's
That's just
160
that's an
now.
acceleration. Have you not done your CTG training recently? Or?
Yeah, I have, but I cannot really see it going down anymore, and the variability is not there anymore. It's as well, like she's...
Well, that's only 10 minutes. Like, we can't really interpret that. I'm honest. I'm not worried about that at all. I think you just need to give her a bit more time, give her something to drink, put her on left lateral, and carry on the CTG for a bit. Like, this isn't a reason to not induce this woman, you know. Like, did you speak to the coordinator?
Yeah, the coordinator asked me to come and fetch the SHO, but the SHO was a bit busy, so that's why
I saw the SHO just in room 2. I think you can get them from there.
I really tried, and I'm concerned with the CTG, so I really wanted to talk to a
But
doctor, you know.
I'm not concerned, so I don't think she needs to be seen. But look, you know, I'm just finishing this, and then I'm going to go to theatre.
Mhm.
So if you don't manage to sort it out by then, I'll pop my head in. But honestly, there's nothing to be worried about.
Okay, okay. So we'll wait for you.
Yeah. All right. All right. Yeah. Go on. Yeah. Tell me about the patient then. Who's this?
Yeah. So as I said, this it's a primate, 33-year-old. She's here for an induction for reduced fetal movements. So I put her in the CTG just to see, like, before starting a propes.
Yeah.
However, I'm not happy with the CTG. I'm not happy to start the propes right now.
What's wrong with the CTG?
So as I said, the baseline is going higher, almost 160 now. Variability is 3 to 5. It has been lower before. Now it's 3 to 5. We change position. Which is every.
I don't know. I think it's difficult to interpret that CTG. We've barely got 10 minutes there, and you know, is she feeling movements? Is she?
Yeah, baby's
normally
moving well, but
grown.
baby had reduced fetal movements 3 days.
Okay, but it's moving fine now, and I mean, it looks like it's accelerative to me. Look, I don't think this is concerning, and I've got something I need to do, and then I'm going to theatre. So, look, I think you can just sort of continue the CTG, and we'll review it when we get out of theatre. But try and get the SHO in the meantime, okay?
Sorry, I've tried getting the SHO, and that's why I came to you, because I couldn't find them, and because I'm still worried. I think I'll have to go and escalate it to the consultant on call, because
I
I'm
think
really
that's
not happy
not
to start.
appropriate. So,
Hi.
This is a very useful mnemonic in escalation. So when you are escalating a clinical situation, you need to choose your words clearly so that you are able to use the safety critical language. So your colleague to whom you are escalating is able to understand whether you are telling them about their concerns just to seek advice, or you are informing them so you are aware of the situation as well, and then you will be able to take a decision based on that, or they want you to do something because it is a serious emergency and something needs to be done urgently. This is particularly important if you think that you are on call and your registrar calls you in the middle of the night and they start telling you a long story. Do you think you will be able to comprehend what they are telling you at that time, especially if you had a busy day and now you have gone to bed and you are really tired and fast asleep? So, this is where the language that we use, the words that we use, the way we convey our information to our senior helps, and that's why we have to be very clear and concise in that. When a colleague escalates concern to us, we have to look at the situation, whether we can explain to them that why you think that there is no need for clinical concern and no need for an immediate action to be taken. Or if it's a serious clinical emergency and somebody is escalating it to you, then you are going to deal with it, take action, and afterwards, then you can sit with your colleague and explain to them about why it was necessary and what were the pros and cons of that. When you go on call, remember that you may be working with a new team. You need to know who is on call with you. You need to know what are their capabilities. And then you also need to know if who to whom they can escalate any concerns. And then even as a consultant on call, whenever I go to work, I still tell one of my seniors if I have a serious emergency, or if I have a case which is a high risk situation and I may need an extra pair of hands to help me in the middle of the night. I prefer to tell my colleagues early on so that they know that if I'm escalating a concern to them, then I want them to be there, which is essentially uh, the do element, okay, of that 8 mnemonic that we talked about. So now we will talk about why escalation fails or we don't escalate. So sometimes we delay escalating because we are sitting on something and think, okay, we will wait for another hour, 2 hours, and then see what happens. So a common scenario on labor ward, you see an abnormal CTG, and then you think that, okay, let me see what happens after 1 hour or by next vaginal examination. Sometimes you become fixated on a particular plan, especially if you think of a situation, you take a patient for trial of instrumental delivery to theater, you apply one-twos which fails, then you put forceps, and then you keep pulling. So that's why you need to set a bottom line that, okay, we are going to apply 2 pulls, 3 pulls, and if we don't see any further descent, then we are going to proceed to emergency cesarean section. Sometimes we feel reluctant to escalate it to our seniors because some seniors they don't like that juniors they come and talk to them directly because of hierarchy. They want you to go, they want a registrar to go to a senior registrar first, or a midwife to go to a registrar first before coming directly to the consultant. Then also another situation could be that you go to another colleague asking, escalating a concern to them. However, what you don't realize is that they are busy, say in theater, doing something urgent, and then you feel you have said whatever you needed to see, whatever you needed to say. Now, that's a wrong approach because you may say all that, assuming that they have understood whatever you wanted to say, and then they also may be overloaded with information at that time. They may not be able to comprehend what you were trying to say, or they may think that they will follow it up, but then they forget. So it is important that you are clear and you choose the appropriate time and the person to convey that concern as escalation. So, in order to promote effective clinical escalation, you need to have psychological safety in that department. So, what is psychological safety? Psychological safety is essentially building a culture where anyone can speak up without any fears of repercussion. In summary, you should be able to recognize a situation that needs escalation. You should be able to communicate it clearly and act on it in a timely manner. And there are certain tools available like SBAR tool for communication. Then we have teach or treat tool as I showed you on our slide earlier, and aid mnemonic as well. And in order to promote the use of these tools, we have to flatten the hierarchy in our department, because if we have a fear of seniors in the department, your juniors will not be able to speak up. They will not have that psychological safety to express their concerns. And remember, escalation saves lives. I will conclude here. I hope that you found this talk useful and you will be able to take home some messages and utilize in your clinical practice to promote patient safety. Thank you.
Thank you, Dr. Wasim. Speaking up does not make us bad doctors. It actually makes us safe doctors. And it's really important to have good escalation and effective and timely manner. Just a reminder for the rest of the presenters as well that the sessions are strictly 10 minutes. First bell is at 8 minutes, second one at 9, and then the third one is at 10 minutes, which is the final conclusion of your presentation. Our next presentation is a very interesting topic. Managing Labor Backache, a comparative analysis of sterile water injections and diclofenac. It's a very interesting topic and is being presented by Dr. Naushila Javed, who is head of the department at PIMS, Obs and Gynae. Thank you. Dr. Naushila.
I will be presenting on behalf of Professor Dr. Naushila, HOD Obs and Gynae from PIMS Institute, from Pakistan Institute of Medical Sciences, Islamabad. The title of my presentation is Managing Labor Backache. It is a comparative analysis of sterile water injections and diclofenac. Severe low back pain affects up to 1/3 of laboring women, often continuous and sharp between contractions, that increases the maternal distress and intervention requests. It may negatively affect birthing experience. The objective of the study was to compare the efficacy of intradermal sterile water versus intramuscular diclofenac for severe labor back pain. The secondary objectives included maternal satisfaction and to evaluate the adverse effects. It was a prospective comparative interventional study. It was conducted for a period of 6 months at Mother and Child Hospital, PIMS, Islamabad. There were 300 primary gravida women, 150 in each group. The inclusion criteria was primary gravida at term in active spontaneous labor, having singleton pregnancy, and those with severe back pain, that is visual analog score of more than or equal to 7. Those having allergy to any NSAIDs were excluded. Those having any infection at the injection site or having prior analgesia in the current labor were also excluded. Patients with preeclampsia or any sort of fetal distress were excluded from the study. So, as already stated, 150 participants were enrolled in the group A and 150 in the group B. In the group A, 0.5 ml of intradermal injections were given at the site of sacral Michaelis rhomboid. In the group B, a single 75 mg of intramuscular injection diclo was given at the site of ventrogluteal muscle. The primary outcome was pain intensity that was measured using visual analog score. It was measured at the baseline, at 15 minutes, at 60 minutes, and after 2 hours. The secondary outcomes were maternal satisfaction and the adverse effects. I think this one is not the revised presentation, so the tables are not complete. The outcome was that in the group A, in the women that were given the sterile water injection, the visual analog scores were less as compared to the group B. At baseline, it was 9 in the sterile water injection, and after 2 hours, it was decreased significantly. Similarly, the maternal satisfaction rates were also higher among the women in group A. The adverse effect in the sterile water group was only a side sting. However, the adverse effects in the diclofenac were minimal injection discomfort. However, there were no maternal side effects observed. It has to be noted that NSAID use in late pregnancy requires caution due to the potential ductus arteriosus constriction. So in both the groups, we observed significantly reduced pain. However, the sterile water demonstrated faster onset of analgesia and higher maternal satisfaction. It is a simple, low-cost, non-pharmacological option that can be offered to the women in labor. Thank you.
Thank you so much. So our next presenter is Dr. Sawalia Khalid Petiwala, who is presenting Maternal Fetal Medicine Unit, Vaginal Birth After Caesarean Section, Calculator Validation at a Tertiary Care Hospital of Pakistan.
Good morning, everyone. I hope everyone is having a wonderful time today. I'm Dr. Sawalia Khalid Petiwala, and I will be presenting on prediction of trial of labor after caesarean success using the Maternal Fetal Medicine Unit calculator at the Khan University Hospital of Pakistan. I have been very graciously supervised by Dr. Zahina Islam, who is a maternal fetal medicine consultant at AKUH. Thank you, ma'am. I would also like to give acknowledgement to my team members without whom the completion of this study would not have been possible. Further thanks to Dr. Nazli Hameed and the IRC Summit for presenting us a platform so that we can present our studies. All right. So the background of conducting this study was the rising cesarean section rates globally, especially in Pakistan, which exceed the WHO recommended rate of 10 to 15%. In some areas, it is as high as 40% simply because of patient preferences, any medical legal concerns, any limited labor support, or simply because of institutional protocols. The trial of labor after cesarean, simply known as TOLAC, offers a safe and a clinically endorsed alternative to a repeat C-section in selected women. It helps to lower healthcare costs, earlier return to postpartum recovery, and a faster discharge from the hospital. The accurate prediction of the trial of labor after cesarean success using the calculator improves counseling and decision-making for the patients and clinicians alike. There was also limited evidence on applicability of the maternal fetal medicine unit calculator in the Pakistani population, which is why we conducted this study in our hospital. There were two objectives to continue doing this study: to evaluate the validity of the MFMU TOLAC success calculator in Pakistani women, and to determine its predictive accuracy in the local clinical setting. All right. So for the study design and setting, we did a retrospective cohort study. This was done at the Khan University Hospital of Pakistan from a time duration of January 2022 to December 2024. So it was conducted over a period of 3 years. The sample size was 149 women who attempted a trial of labor after cesarean, and it was a convenience sampling. In our study population, we had certain inclusion and exclusion criteria. The inclusion included single prior lower segment C-section women who were willing to attempt a trial of labor after cesarean. So anybody who refused a TOLAC or who wanted to get a cesarean done for maternal preferences was excluded from our study. Certain other exclusion criteria include anybody who had a previous classical C-section scar, anyone with a uterine rupture, anyone with multiple gestation in this pregnancy, or those having incomplete data. The key techniques and tools utilized in this study were that data was extracted from hospital medical records, which is the MR number for the patients. The MFMU TOLAC success calculator scoring was done for each patient at early admission and at delivery, at early pregnancy and at delivery admission. And statistical analysis was done using the SPSS. So out of 149 women in our sample size, 75 of those underwent a successful trial of labor after cesarean section. There were significant predictors of success that we noticed in these women, significantly being one or greater than one prior vaginal birth contributed very highly to a successful trial of labor after cesarean. A previous successful TOLAC was also a significant predictor of success. Greater cervical dilatation and effacement at delivery admission was noticed in those undergoing a successful trial of labor after cesarean. Higher failure was, however, noted in those patients who had a prior C-section for non-progressive labor. So this is the table that shows the baseline characteristics of pregnant women for trial of TOLAC. Here you can notice that a prior vaginal birth of 1 to 5 at least showed that successful TOLAC undergoing women were 56% as compared to only 28.38% of unsuccessful TOLAC. Similarly, history of TOLAC, those having a history of TOLAC underwent a successful TOLAC in this pregnancy, 37.3% compared to 10.8% only, with a significant p-value. Furthermore, non-progressive labor in the previous C-section indication showed that 37.84% of women had an unsuccessful TOLAC in this pregnancy compared to 20% of successful TOLACs. I know this can seem like a very complicated slide, but let me break it down for you. So this is a comparison of pregnancy characteristics and maternal and neonatal outcomes. Here you can notice that the women who underwent a successful TOLAC had significantly higher cervical dilatation at admission for delivery, and a significantly higher cervical effacement at admission for delivery as compared to those who did not undergo a successful TOLAC. So our main conclusion findings are: the MFMU calculator performed better at delivery admission as compared to early pregnancy. In early pregnancy, our cutoff was 64.6%. So anybody who had a calculator percentage of 64.6 or above was told that they had a sensitivity of 72% and a positive predictive value of 65.8% to undergo a successful labor trial. So these were the women who were given these choices, and they could go for a trial of labor in this pregnancy. This positive predictive value jumped up to 83.6% at delivery admission, with a cutoff of 76.6% and a sensitivity of 68. There was also low and comparable maternal and neonatal complications for both groups, supporting TOLAC safety in selected women. There were certain implications that helped us support offering TOLAC to eligible Pakistani women to reduce repeat C-section. The calculator was found to be more reliable when used for delivery admission, and it was a useful tool and a clinically endorsed alternative for counseling and decision making for women so that they can go for a trial of labor after cesarean instead of a repeat C-section. However, there were certain limitations and future directions that need to be mentioned. It was a single center, small sample study. It does need multi-center validation or development of a locally calibrated model, which we hope to do in the future. Thank you so much, everyone.
The next topic is by Dr. Ghazala Iftikhar about reliability of Doppler ultrasound for placenta previa, a study based on surgical confirmation.
Bismillahirrahmanirrahim. My study is about diagnostic accuracy of Doppler ultrasound in detecting placenta previa and accreta spectrum using intraoperative findings. Placenta previa was originally defined using transabdominal ultrasound as placenta developing within the lower uterine segment. Two centimeters from the internal os is the cutoff limit. If it is within 2 centimeters, it's called previa. Otherwise, it's called anomaly situated placenta. 4 types of previa as its relation with the internal os. You all know about these. And these are further subdivided into minor, as grade 1 and grade 2 are minor. Grade 3 and 4 are categorized as major placenta previa. Incidence of placenta previa is 0.5% at term. In contrast, placenta accreta is a histological term and is defined as abnormal adherence of the placenta in part or in whole to the underlying uterine wall in the partial or complete absence of the decidua. Here you can see placenta accreta, its mere attachment to the lower uterine, to the myometrium. Placenta increta, that the placental villi are going deeper into the myometrium, and the placenta percreta when all the layers of the myometrium have been invaded and it reaches up to the serosa. It may go up to the bladder, or it may even invade the surrounding pelvic organs as well. These are the same grade 2 and grade 3 subdivided into 3 further parts. So placenta accreta spectrum is a disorder ranging from abnormally adherent to deeply invasive placental tissue. Rationale of my study is early and accurate prenatal diagnosis of placenta previa and accreta spectrum is essential for surgical planning, blood products preparation, and multidisciplinary management. Doppler ultrasound is widely used for diagnosis. Placenta previa is a leading cause of antepartum hemorrhage, leading to severe maternal and neonatal morbidity, increased cesarean delivery, risk of PPH, and placenta accreta spectrum disorders. Objectives of my study are to assess the diagnostic accuracy of Doppler ultrasound in detecting previa, and to compare Doppler findings with the intraoperative findings, to evaluate its role in identifying placenta accreta spectrum. It was a cross-sectional study done in Social Security Hospital, Multan Road, Lahore, over a duration of 4.5 years, from March 2021 till October 2025, and sampling technique was non-probability consecutive sampling. A total number of 214 patients were followed by surgical delivery. Exclusion criteria was normally situated placenta. Statistical analysis was done at SPSS version 27, determining sensitivity, specificity, positive and negative predictive values, and overall diagnostic accuracy. Mean maternal age was 31 years, while mean gestational age at delivery was 35.6 weeks. 61 patients underwent caesarean hysterectomy, while in 152 patients we were able to conserve the uterus, and one patient was referred due to the non-availability of Rh negative blood group. Most of the patients, that is 81, were done as elective procedures. In 3.3% of the patients, there was repair of the bladder, and in another 3.3%, urinary catheter was retained for 2 weeks. Most of these patients, that is 86%, were done under spinal anesthesia. As the history of previous surgeries, you can see that only 4.2 patients had no previous surgery. 2.34% patients had only history of abortions. But the major chunk was having previous 2 and previous 3 caesarean sections. 13% had previous 4 caesarean section, and 1% had previous 5 and previous 6 caesarean sections. So previous caesarean section is the major culprit. Diagnostic performance of Doppler ultrasonography as regards placenta previa was found to be, sensitivity was between 82 to 100%, and specificity was 92.9 to 99.5%. Highest diagnostic accuracy was seen for placenta previa type 1 and type 4, showing strong agreement with the intraoperative findings. These are the graphical representations of the same: sensitivity, specificity, positive, negative predictive values, and overall accuracy. Regarding placenta accreta spectrum, sensitivity of Doppler ultrasound was found to be 83.7%, and specificity was found to be almost 92%. Overall diagnostic accuracy was more than 90%, showing that Doppler ultrasound has good predictive value for placenta accreta spectrum detection. This is the comparison of Doppler findings with the intraoperative findings, showing how closely these findings are related to each other. You can see placenta increta, 100% findings are the same as Doppler and as intraoperative. In placenta accreta and in placenta percreta, these findings very closely relate to each other. 61 patients who underwent caesarean hysterectomy, we were able to trace histopathology reports of 52 patients. 50% of these patients had placenta accreta, 40% had placenta increta, and 10% had placenta percreta. Comparison of, when we compare histopathology report with the Doppler ultrasonography report, you can see that in 56% of the patients, it was exactly the same, it was 100% the same. And in 17.3% of the patients, Doppler showed lower invasion, while in 26% of the patients, Doppler showed higher invasion than the histopathology. But in all the cases, Doppler did pick up the invasion. 44 neonates, while 6 mothers were admitted in the intensive care unit. In conclusion, Doppler ultrasound findings correlate well with perioperative and histopathological findings regarding placenta previa and placenta accreta spectrum. So, preoperative mapping of placenta previa and placenta accreta spectrum with Doppler ultrasound is a must to decrease fetal-maternal morbidity. Future implications of my study are that it facilitates preoperative planning, risk stratification, and surgical preparedness. Adjunct imaging can be used for complex cases as MRI. Limitations of the study are potential biases in operator experience and variations in diagnostic criteria. Recommendations for future are development of validated AI-assisted Doppler ultrasound tool, automated measurement of placental edge to os distance, and AI-based risk stratification model for hemorrhage prediction. So, take-home message is placenta accreta spectrum. Anticipate, prepare, and prevail. These are the references of my study. Thank you so much for your patient listening.
So, our next study is a surgical journey of uterine preservation in 39 high-risk cases of placenta previa and placenta accreta spectrum from 2017 to 2024 at Shifa International Hospital, Islamabad. And this is being presented by Professor Dr. Shazia Fakhr, who's the head of the department.
So, Assalamu alaikum, my seniors, dear colleagues and friends. Today I am going to unfold the most controversial topic in my department regarding the management point of view. And I am here to share this journey from 2017 until 2024 of uterine preservation in 39 high-risk cases of placenta previa and accreta spectrum. So there is a slight overlap from the previous presentation. So we all know that the incidence is at a rise because of the rising rate of cesarean sections, and placenta accreta is the most common but least invasive form with a prevalence of 1 in 300, while placenta percreta is least common yet more prevalent with a prevalence of 1 in 2000. So this placenta accreta spectrum is associated with massive obstetric hemorrhage, need for massive transfusion, ICU admissions, and maternal morbidity. Planned caesarean hysterectomy remains the cornerstone of management, causing permanent loss of fertility and a great psychological impact over the woman. This is a pictorial presentation of the invasion of the placenta within the myometrium, and according to which we divide it into accreta, increta, and percreta. So what is the rationale for uterine preservation in all these women when the standard management is caesarean hysterectomy? Because there is an increasing number of women with incomplete family. There is a big psychological and reproductive impact along with the social impact on the life of a woman after hysterectomy. There is an emerging interest in uterine sparing techniques, and that has been emerged for the last 1 or 2 years. And there is a limited long-term data from low and middle income countries. So objectives of this study was to assess the effectiveness of uterine sparing modalities in managing the placenta accreta spectrum utilizing advanced surgical techniques. The secondary objectives were to determine the rate of successful uterine preservation, to assess the intraoperative blood loss and transfusion requirements, to evaluate the perioperative and long-term maternal complications, and to document the need for emergency hysterectomy in cases where we try to save the uterus. So it is a retrospective observational studies of all the cases of placenta accreta spectrum presented to Shifa International Hospital and it is a single surgeon experience from 2017 till 2024. It's a quaternary care hospital, and the data source was electronic medical record and confidential medical record. There was a multidisciplinary team involvement, including collaboration between the obstetrician, anesthesiologist, hematologist, urologist, intervention radiologist. The surgical strategies which we used were uterine artery embolization, internal iliac ligation, adjunctive surgical techniques, which include stepwise devascularization, hemostatic sutures over the myometrium or the placental interface with the myometrium, and placental site excision, that is myotomy, which were carried out on case-to-case basis. So total number of patients during that time period was 39, and 32% of the cases were performed as an emergency, while 68% were electively performed. General anesthesia was given in 31.7% of the cases, while 68.3% were performed in spinal anesthesia. Our primary outcome was uterine preservation, and fortunately, we were successful in saving the uterus in 38 out of 39 cases. This 39th one was also saved at the time of surgery, but after 4 or 5 hours, she started rebleeding, and we need to reopen her and do a re-laparotomy for her. So the distribution of the subtypes include 9 cases of accreta, 13 cases of increta, and 17 cases of percreta. The surgical interventional techniques which were used were uterine artery embolization, where complete embolization was performed in 7 cases, ballooning of the uterine artery, which was performed in 4 cases, and that those balloons were deflated after the procedure, and proper embolization was not performed in those cases. Internal iliac ligation was performed in 11 cases, and surgical techniques and uterotonics were applied to all the cases. So multiple surgical techniques are there. Some people prefer to leave the placenta in situ, but none of our case has the placenta in situ, which was left there. We take it out, decide there and then, and take our final decision. So first of all, and in all these cases, approach was through the lower segment and directly through the placenta, and not a single case classical incision was given. Intramyometrial incision, uterotonic injection was used, or uterotonic was given through the cord. The placenta was separated in the piecemeals, and the chunks were separated further from the lower segment and whatever places they are adherent with. And sometimes there was no lower segment identifiable. So the whole bed was stitched with hemostatic sutures with Vicryl 0 over a long needle to include the whole depth. I forget to mention the use of hemostatic agents like Surgisil and intrauterine and vaginal packing also. So you can see this is the demarcation of the bladder, and this is the bladder peritoneum, and this is the whole lower segment which is replaced by the placenta, and only the serosal surface is visible. Here it is more clearly visible, the whole placenta which is occupying the lower segment. So in this case, this is a case of increta, where we remove the placenta completely. You can see even some fenestration here in this leftover serosa, where there are some fenestration and little myometrium, areas of myometrium. So all this chunk was removed, the tissue was remodeled, and finally a neat and clean scar was given to the uterus, and it was stitched. with the rest of the tissue. So the blood loss ranges from 1000 to 2500 ml, and the post-operative outcomes include re-laparotomy, like I explained previously, in one case, postpartum hemorrhage in 2 cases, which was managed afterwards conservatively, and they don't need to take to the theater. Bladder catheterization for up to 2 weeks was required in 5 cases, and there was a subsequent pregnancy in 7 cases. These 7 cases are those who come back to us for their pregnancy and pregnancy care. Regarding rest of the cases, we don't know. And in 15 cases, we performed BTL. So, regarding the long-term complications, only 1 case of infertility post-hysterectomy. Rest of the cases, there was no fistula formation, rectal injury, wound dehiscence, niche formation, or scar rupture in subsequent pregnancy, as far as we know in these 7 cases. So the reproductive outcomes is again a promising field point, and we can see that 7 patients achieved pregnancy successfully without any scar rupture, and this support a functional uterine preservation in all those cases. So conclusion of the study is that uterine preservation in patients with placenta accreta spectrum is an achievable and effective approach when endorsed by meticulous surgical planning and a multidisciplinary approach. Embolization and internal iliac artery ligation contributes significantly to reduce the blood loss. In more than, not 97, we use it in 52% of the cases of the targeted population. This study highlights the importance of investing in surgical training, intervention radiology collaboration to manage the high risk to preserve the fertility of a patient. Wider adoption of techniques have shown to improve maternal outcome, but also reduce the psychological impact associated with loss of fertility and a loss of uterus also. Larger prospective studies are needed to redefine the patient selection and long-term outcomes. Thank you very much.
Thank you so much, Dr. Shazia. An excellent presentation. If we could have the telephones on silent, please, that would be really lovely. It is a very interesting topic, and I understand that we feel like discussing it now, but it would be good if we could do the discussion later and give the sessions the due amount of silence from our side as well, please. So, given the theme of placenta accreta, we've heard one presentation from Lahore, one from Islamabad, but the problem is they're all over Pakistan, and the next presentation is from Sialkot on placenta previa and placenta accreta spectrum, obstetric risk factors and fetal-maternal outcomes at a tertiary care hospital at Sialkot by Dr. Nausheen Bano.
Bismillahirrahmanirrahim. My respected seniors and dear colleagues, I am Dr. Nausheen Ali. I am working as assistant professor at Khwaja Muhammad Safdar Medical College, Sialkot. The title of my presentation is Placenta previa and placenta accreta spectrum obstetrical risk factors and fetal-maternal outcome at Tertiary Care Hospital of Sialkot. This study was performed under kind supervision of Professor Sumaira Aslam, that was working as a HOD, and she is not available right now here. Background of study was that placenta previa globally prevalence is 0.26 to 2%, but its incidence is very high in Pakistan. Major risk factor is previous C-section. It is associated with postpartum hemorrhage, placenta accreta spectrum, hysterectomy, and neonatal complications. The rationale of my study was many women in low resource settings continue to present late, and they are contributing to higher mortality and morbidity. The objective of study was to evaluate the obstetric risk factor associated with placenta previa and placenta accreta spectrum, and to assess the feto-maternal outcome in the pregnant women presenting at a tertiary care hospital of Sialkot. Methodology study design was retrospective analytical cohort study, and the duration of study was 1 year, starting from 1st January 2024 to December 2024. The selection criteria, among them, all the women were included who presented in emergency or OPD of Allama Iqbal Memorial Teaching Hospital, either per-op or intraoperative diagnosis of placenta previa or placenta accreta spectrum. And the exclusion criteria were only those women which were having either twin pregnancy or any malignancy. Data collection was done, and demographic, obstetric, operative, and neonatal data was collected, and the maternal outcome was assessed in terms of hemorrhage, transfusion required, and hysterectomy and ICU admission. Neonatal outcomes were studied in terms of mortality, morbidity, and ICU admission. Data was analyzed through SPSS version 25. These were the results of my findings. The main risk factor was found to be the cesarean delivery, previous evacuations, and placenta accreta spectrum. These are all about the data collection. The total number of patients included in the study were 48, and the mean age at presentation was 30 years, and less than 30 years there were 20 patients, and more than 30 years there were 28 patients. Mean gestational age was 35.6 weeks at presentation, and 50-50 were booked and unbooked. And 14 were referred cases received from the periphery of the Sialkot that were totally unbooked and without any investigations, without any workup, and without any prior knowledge of placenta previa or placenta accreta. The gravidity was less than 3 in 14 women, and more than 3 was in 34 women. Previous C-section was in 37 patients, and history of DNC was in 17 patients. And placenta accreta spectrum was in 21 patients, and the minor risk factors were assisted conception, subfertility, endometriosis that account 2 cases in each. And endometriosis, fibroid, and smoking was 1 case each. Cesarean section required was, it was emergency cesarean section in 64.6%, and elective cesarean delivery was performed in 35.4% of the cases. Interventions done in form of hysterectomy, B-Lynch, internal iliac ligation, and combined procedures. Hysterectomy was done in 20 patients. Out of 48 women, 20 were hysterectomies. And B-Lynch was applied in 15 women. Internal iliac ligation done in only 1 patient because we have a limited resource setting and no availability of the expertise at most of the time, as the patients present at midnight or late in the evening where the surgical expertise are not available at most of the time. Combined procedures was done by our own team in 12 cases. Blood transfusion requirement was massive. Among the 48 patients, 92% patient required blood transfusion requirement and 8% minor transfusions. Maternal outcome was studied in terms of blood loss, number of transfusion required, hysterectomy, and ICU admission, and at the same time, neonatal outcome was studied in terms of gestational age at delivery, mortality, and NICU admission. Among the maternal outcome, the placenta accreta was diagnosed in 21 cases, that accounts for 43.8%, and hysterectomy and maternal ICU admission was in 20 cases, that accounts for 41.7%. And there were unexpectedly 2 maternal deaths that presented at very low HB, 2 or 3 at the time of presentation. and it accounts for 4.2%. Primary PPH was in 52.1%, as the most of the patients present unprepared and they are unaware of their diagnosis and they are unaware the gravity of the situation. It is all about maternal outcome. The death is blue and hysterectomy, and its death, hysterectomy, and placenta accreta spectrum, and ICU admission. The neonatal outcome was studied in terms of preterm that were 50%, low birth weight was 29.2%, and NICU admission was in 31.3% of the babies. The neonatal deaths were 7. They were extremely premature, and it accounts for 14.6%. It's about the neonatal outcome. The conclusion was the placenta previa and placenta accreta spectrum are high risk. Early diagnosis and multidisciplinary care can improve the outcome in low resource settings. I just want to clarify the situation in my hospital. These are the statistics of last 6 months from August 2025 to January 2026. Total cesarean sections performed were 2,000 and total SVDs were 2,500, and among all them, the total placenta previa cases were 106 in last 6 months. And total placenta accreta spectrum were 45, and obstetrical hysterectomy performed were 30, and most of them were unprepared and totally without any antenatal care, without any investigations. Thank you very much.